complex arthroplasty unit. My main workload is joint replacement. Half of the workload is first-time joint replacement or complex joint replacement. The second half of joint replacement is redo surgery or revision surgery, or at least seeing a lot of patients who had a painful joint replacement. Doesn't mean everyone need painful joint replacement will require revision surgery, but of course depends on the cause. And I also work at SWL, hence the invite today. SWL, as you know, is a share between the 5 different hospitals: Croydon, St Helens, Epsom, and Kingston Hospital. Operate there weekly, and there we do the primary joint replacement. We do some type of revision work as well there. And I guess the talk we're going to talk about is why sometimes patient after hip or knee replacement unhappy, and why sometimes the patient moaning. And why a lot of us, we hear the complaint that knee is not as good as a hip, or other different complaint. Well, we're going to tackle some of the problem that we commonly face after joint replacement. And I'm happy to take any question either during the presentation, or we can have a discussion toward the end of what you thought, and hopefully we can learn from each other. So first of all, most important to establish the fact that joint replacement is really very successful operations, whether they're hip replacements or knee replacement. And not surprisingly, you find now the waiting list for both of these operations is massive, because a lot of patients, they want to have this operation. They have this operation before and they want it to another joint of their body, or they know someone have it, and the evidence is very clear. They are very operation that will change the quality of life to a significant degree. They are very cost effective in improving the quality of life, and that's the reason the hip replacement, for example, was long time ago labeled the operation of the century. Has very good change in the quality of life of our patients. And not surprisingly, we see patients with multiple arthritis. Once you do the first joint, they come back to you after 6 months or 2 months. They want the other joint to be replaced. And we're looking at the same apply with the knee replacement. So if you look at the national data, the satisfaction rate for the hip replacement around 90%, and for the knee replacement around 83%. So that when you ask all the patients, the compliant patient, not compliant, high risk, low risk, good surgeon, world expert surgeon, average surgeon, everyone, you put them in the same basket and you ask them after 1 year, how do you feel? 83% of this patient, they are satisfied. They feel the pain a bit better, much better, excellent. Depends on the various, but they are happy, they satisfied. So it's good, really good percentage. And we have moved a long journey in the implant survival over the last 20 years. While people 20 years ago, they were so concerned the implant may not last very long, and they will always, when someone young need a hip or knee replacement, they tell them you're too young to have a hip or knee replacement. That thought has changed, and that thinking has changed, because we know now, if you look at the National Joint Registry, at 15 years follow-up, more than 90% of the implants still there in place after 15 years, regardless how active the patient, regardless of the type of fixation, cemented, uncemented, mixed, hybrid, cemented and uncemented. After 15 years follow-up, most patients, they still have the implant in place. So we have done really good steps in achieving good satisfaction, good successful result, and excellent survival for the implants. But the reality is not 100%. And we will, as much you think 90 is really good, but everyone wants to achieve the best result and the better result. And we try to aim to get as closer as 100 as possible. And the only way to achieve that and improve our satisfaction rate is to know what things are putting us down, when things goes wrong, and why they go wrong, how we can avoid them, how can we recognize them, and if we recognize the problem early, we can treat the problem early. And that's what we're going to talk about. There are many reasons why after joint replacement, the patient might not be satisfied or they might run into trouble. The reason varies between infection, between a fracture, instability of dislocation of the joint, between implant loosening, soft tissue irritation, technical, maybe they have the wrong operation, maybe they didn't have hip arthritis, or they were not symptomatic from the hip arthritis, they're symptomatic from the spinal pathology. or maybe they have DVT or heart attack or other medical problems make them unsatisfied with this outcome. Each one of these problems are topics in its own, and you need half a day to discuss that topic in depth. But we're going just to shed some light on some of them, just for some areas which is most important, and then we have discussion at the end if anyone has any questions on any of these areas. So one of the big problems we have in the acute phase after joint replacement is the wound healing problem. Wound healing problem happens for many reasons, from the quality of the soft tissue, if the patient overweight, obese, a lot of fat tissue, the quality of the surgical technique of the wound closure, the DVT prophylaxis we use between rivaroxaban and between apixaban, very strong mechanical anti-thrombotic agents. All these contribute to different types of wound healing. And wound healing can just broadly divided into 4 areas: stitch abscess, cellulitis, wound dehiscence, or underlying deep joint infection. So we start with stitch abscess. Stitch abscess is really common. Stitch abscess is not an infection most of the time. It is just an active inflammatory process to the suture material. Usually the white suture material that most surgeons use, the undyed vipal type material under the skin. And because it's very close to the skin, you have that non-infective inflammatory process. You have, just like the appearance in the photo, small wound opening up. And if you squeeze it, there will be some white fluid coming out. And that's stitch abscess. This is not infection. What's happening there, when we have any foreign material inside the body, like the suture, the joint cell will react to it, which is joint cell type of white blood cells as defense mechanism, recognize this foreign material. And sometimes you have that inflammatory process against that material, producing that white fluid you see. It's not really pus, it's almost a sterile abscess, if you like. So how do we deal when we see stitch abscess? We will clean the wound, trim the end of suture. Sometimes you're able to pull the end of the suture and just trim it and apply dressing. Routine antibiotics we don't need for these stitch abscesses. If you do blood test, the CRP should be still 12 or 10. But you may want to give them a prophylactic antibiotics if you thought actually the skin not great, the dressing, this patient is probably need more attention, they're very high risk, there's big hole there. You may elect to give them prophylactic antibiotics, but you don't need routinely to give them antibiotics. You're very happy to treat them as a wound dressings and keep close eyes on them. The second issue is the skin cellulitis. This is skin superficial infection. This is really hard problems when it's around the scar area itself. If the cellulitis happening in around the foot or around the ankle, is much easier to recognize. This is isolated cellulitis, is far away from the surgical site. The difficulty when the cellulitis is happening around the scar area, is this cellulitis or is this deep joint infection? And it's really, really hard to differentiate sometimes between one or another. Cellulitis by default is a skin infection, so the joints will still be pain-free. But remember, in the acute phase, all patients will have some degree of swelling and pain in their joints. So to be completely pain-free, it is a bit hard. And that's where you come, if the pain has suddenly increased more, you more think this is deep joint infection. It's come between the experience of the person examining this patient, between clinical diagnosis, between the suspicion. Doing blood tests is also very useful. CRP markers is useful. Excuse me, because if the CRP come up very high, you will think most likely toward the deep joint infection than actual cellulitis. However, the important things in cellulitis, the joint should not be painful. The patient tell you, the joint, no, I don't have pain in my joints, just this redness coming up, it's a bit warm, it's a bit sore, the skin when you touch it, but the pain is actually fine. Then that will think you more towards cellulitis, skin infection. But if the joint itself painful, then make you think more into deep joint infection. Wound dehiscence, we don't see it often. It does happen still, and it's really hard to say at what stage you decide this dehiscence need to be taken back to the operating room to be washed out the wound and close the wound more formally, or I can still manage it with regular dressing and make it heal by granulation tissue. And that's comes down to the expertise of the person deal with it. This is not a simple dry dressing applied to it. There are so we're so fortunate at George's at EOC, we have specialist nurses who are specialized in that area, and they should be able to manage with different type of dressing and try to monitor them very closely. But it's quite labor requirement, these type of wound, because you need to keep close eyes on them. Sometimes you need to see them twice, 3 times a week, keep very close eye on them, and then you have the expertise and you have the right decision at what stage you say, actually, no, this is beyond dressing, operative management. I need to take this patient back to the operating room, open the wound, wash it, and close it formally. And these need more surgical attention, need to be referred directly back to the operating surgeon, and they can then make the decision based on the facilities they have, based on the expertise they have, and based on the caliber of the patient and the wound itself. And just to put this is very important fact. Wound swaps has no value. There's no point to do any wound swaps for any of these wounds. And a lot of people love doing wound swap. For me, I even don't check the results when a patient comes wound swap, because it doesn't mean anything. This is skin flora, and this is always going to create skin flora, and always the sentence will say correlate clinically. It has zero value, just waste of everyone's time. Because if you think there's deep joint infection, you need to take aspiration from and biopsy from inside the joint. The swab on the skin, this is very old-fashioned treatment and has no clinical value whatsoever. And then we come to the monster that we all scared from a joint point of view, is the joint infection. Despite the best effort, everything sterile, we track every single step to minimize the risk of infection, patient being given antibiotic, we use high concentration alcoholic base antiseptic. The infection does still exist and is not zero. It's around 1%. And while we think 1% is okay, not too bad, but actually this is a very big, significant complication. It's I tell my patient always when I can consent them, if infection happens, this is a disaster, because there's no other way to put it around other than you're going to have 2-3 operations after the joint replacement in the aim of reducing or clearing the infection. So the facts about the infection: any suspicion of acute joint infection, this is an urgent refer to the on-call team. This is not a letter I dictate, or I'm going to drop them an email, see what they think. This patient need to be calling to the on-call orthopedic registrar in that hospital and being transferred to the regional hospital, which will deal with joint infection. And we should not start any antibiotics. If someone coming to me to see me and have a knee replacements, let's say whenever, 2 weeks ago, 6 days ago, 2 years ago, and I think now the knee is infected because he said, I was fine until yesterday, the knee is swollen, warm, very painful, I'm not feeling great. I think the knee infected. I will never start an antibiotic unless I'm thinking he's septic. This patient is going to be septic, he's going to collapse. I will start an antibiotic. I will take blood culture, and I hope from the blood culture, I will identify the bugs, the organism, and then I can start on antibiotics as part of sepsis treatment. But if the patient is not septic, CRP40, he's fine, I will not start on antibiotics. And the reason behind it, once we start antibiotics, make the likelihood when we aspirate the knee and we take a biopsy, or we aspirate the hip and we take a biopsy from the hip to identify the actual organism, become really hard. And that will limit a lot of choices after the management. We will never cure the infection by giving them antibiotics, and we'll talk about it in a second. We just develop resistance over time and make the diagnosis always going to be question mark, gray area. Which organism? We don't know what antibiotics. We have to give them broad spectrum antibiotics. And that's all because the management of periprosthetic joint infection rely on 3 main factors: the time of the infection, not the time of the operation, because even if you had operation 16 years ago, you can have acute infection within 2 days ago. So a patient had knee replacement or hip replacement 16 years ago, and suddenly had urinary tract infection or chest infection or anything, and the knee or the hip swollen up, become painful. This is acute infection. This is not a chronic infection, although the operation done many years ago. Depends on the organism. So treating staph epi is much easier than treating MRSA or VRE or any of these. and depends on the host. How is the patient? Is he diabetic, overweight, heart failure, on a blood thinning medication, or someone healthy and the soft tissue in good condition? So all these factors are determine our management. And the main difference in managing infection in joint replacement than if I have tonsillitis and I go to my GP who kindly give me antibiotics, I feel great next day, is what we call is the biofilm. Biofilm is the defense mechanism of the bacteria in the body. So when you have metal, as you can see, this is implant for knee replacement. This is the femoral component of knee replacement. If you put bacteria inside the joint, the bacteria will form a pseudomembrane called biofilm. This is part of their protecting mechanism to protect, shield themselves. And regardless how much antibiotics you're going to give them, you will never eradicate that infection. You're only going to suppress the infection, make it weaker, but you will never going to eradicate them because of the presence of the biofilm. We believe the biofilm form around 4 weeks' time. 4 weeks' time from the start of the infection, but the really difficult question, when did the infection start? It's really hard sometimes because quite often patients come to us with very vague history. I've not been feeling okay for the last 7-10 days. So when did the biofilm start? But we hope from the history we can have a fair idea if it's within 2, 3, 4 weeks, or this has been for last 6 months he's been having painful joints. We believe in the acute phase when there's a biofilm hasn't formed yet, we can still have a chance by opening the hip or the knee, wash out the joint, change the plastic part or the head or something that's easy to be changeable to allow us better access to wash the implants and debride the tissue, and we can still win by treating them with that operation. And during the operation, we take the multiple tissue sample, then we start them on broad spectrum antibiotic like vancomycin, tacoplanine, and until we get the microbiology result, and then we can narrow down our antibiotics choices based on the sensitivity. Here we believe the biofilm has not formed, and we call this procedure debridement and implant retention, commonly referred to as DARE procedure. This patient had a DARE procedure, which means debridement and implant retention. Chronic infection is completely a different beast. Chronic infection, this is infection being for months, and the patient can present completely in different flavors, if you like. In the acute setting, persistent wound oozing after the operation, never sealed that wound, and although initially we're not infected, but because you have an open gate in the skin, like a wound dehiscence, keep discharging, they will get infection, and eventually the joint gets infected. But when the scar heals, the patient can present in different type of signs. They can present with sinus, big hole in the wound, and that sinus keep pouring pus from it. And pus, sinus is as much as is really bad things and is destroying the soft tissue, destroying the joints. From my point of view as a revision surgeon, is actually sinus is my friend, because I know this patient will not get septic soon, because there is an exit for all the pus coming out from the knee. So I don't need to rush this patient tonight to the operating room. The pus is coming out, he's stable. We need to plan surgery for them. Sometimes the patient presents completely different history, like this lady. She's middle age, she had hip replacement done, then revised, and she always never been happy with the hip replacement. Always she had that vague pain, and on and off, vague pain, become unwell. And when we aspirated her, she was infected. And why someone presenting suddenly being unwell, septic, someone presenting with sinus, someone presenting just with vague pain, that determined mostly by the type of organism you have causing the infection. Certain type of organism, they will never going to make you sick or septic. They're just going to make you feel tired, or make the joint is really painful, unhappy, achy joint every now and then. And the only way to manage that, we take everything out. We took everything out, then we cemented what we call the spacer. In this case, I use a normal hip, cemented hip, but I cemented intentionally in a very bad way, in a loose way, so I can come back after a few months. Once I cement this one, the patient will be taken to treated antibiotics with intravenous antibiotics and oral antibiotics. And once I'm 110% sure the infection has been eradicated, we go back, we take our temporary implant out, as you see, and then we put a final implant in place. So this patient ended for 2 operations, and hence we call it 2-stage revision surgery. Sometimes the spacer can be as one of these made. They are just basically a lump of cement. You put it in the joint. And when we decide cement versus cemented implant, this is a surgical decision, depends on the soft tissue, depends on the type of infection. But the patient can still walk on this cement-based spacer, but they have in their joint is a joint made up of purely cement. This is a revision cement mixed with high concentration antibiotics to allow to deliver antibiotics locally to the joint itself, as well as we're giving them the intravenous and subsequently the oral antibiotics. Sometimes we can do the whole thing in one stage. This patient, again, pain for 6-7 months with painful hip. He's in good health. We identify the organism. We have very good sensitivity to the organism, the soft tissue in good condition. So we're taking the old implant out. We washed the joint, debrided the tissue, and then we put a new implant in place. And the implant we elected to use in this occasion is a cemented implant, again, utilizing the benefit of mixing antibiotic with the cement to be helping us with eradicating the infection. So we did this as a single stage revision for infection. So similarly for the infection, chronic infection can present with various degrees of pain. And it is really complex problem and is really draining and affecting the quality of the patient, quality of life for the patient big time. And the complexity of this patient, they all nowadays, national recommendations should be treated with a multidisciplinary teams, and this should be going treated on named tertiary referral center. For Southwest London, St. George's is our tertiary referral center where we base, and that's what we do. Our all infection cases should be done there. So we don't do any infection work at the SWL to be compliant with the national guidelines. We have a micro MDT regular basis. We have a plastic surgeon involved with us. We have a vascular surgeon, as well as the clinical infection team. So microbiologists not only giving us the antibiotics, they go to see the patient in the ward round. When they're inpatient, they see them as outpatient, and we work very closely together, because clearly you need multidisciplinary approach to it. You need the physiotherapist who see all the time these patients. You need the occupational therapist. So all that team input to help to clear this problem. So the message you're going to get, as I say to my patient, is a disaster, because if you have deep joint infection, you're ending up with a big operation or operations. And a patient who had 6-7 revisions for a joint with a knee or hip and were unsuccessful, and they become septic or they become a lot of pain, they may end up with amputation in the rare circumstances. So it's a really big problem. Now we're going to move completely to different cause of pain problems is periprosthetic fracture. Periprosthetic fracture happening during the operation sometimes if the bone's soft, especially commonly with cemented implant, because uncemented implants you rely on you putting a big implant as tight as you can inside the bone to allow you to provide you that press fit or that really tight fit, if you like, inside the bone. And having that balance between you're going to put as big implant to give you tight fit versus breaking the bone is just sometimes become very narrow balance. And hence nowadays, most patients, probably above 70, a lot of surgeons elected to do a cemented component, at least for the stem side, because it minimizes the risk of infection. However, we fully acknowledge age is not a factor. Sometimes you get a 40-year-old patient on dialysis, quite osteoporotic, hardly walked anything, and their bone much softer than someone who's 88, who've been still playing tennis, still in good shape. Their bone is very in good quality. And periprosthetic fracture can happen later on in life, after 10-15 years. Patient can have a big fall, and then most of the time we try either to fix the fracture or we try to revise it. For me, if patient has a joint replacement, has a fall, unable to walk, in my book they're always getting X-ray, because it's really very difficult to differentiate the subtle, small, and displaced fracture that if I pick it up early, I can manage it even sometimes non-operatively by non-weight bearing with the crutches or by very small operation versus the fracture which is displaced completely and require major revision surgery. So the threshold of having X-ray is really important here. Other issues with the hip replacement in particular is the metal on metal hip replacement. This was very popular 15-20 years ago, where everyone thought that's the solution to dislocation. We provide them with a big femoral head, and by having big, large head which made of metal, we cannot manufacture it of ceramic because the ceramic used to break. So having very large metal head will be the solution to that. However, later on, we had quite a few disasters, some of them design related, some of them the nature of the friction between these two metals, and we end up what we call alveolar or pseudotumor. So what you can see on this image, this is cross-section around the proximal thigh, and all this white area here, this is all pseudotumor. And pseudotumor is a fluid collection with all this vasculitis and all this inflamed tissue there. These operations are not the easiest revision to do, because once you revise them, I check this big tumor out, and then you have a big cavity there, and they will have big hematoma there. The soft tissue balance is not going to be very tensioned because everything being stretched. Hence, these patients are at very high risk of dislocation, at very high risk of having infection post-op, because suddenly you have a big cavity in your area around the hip joint because of the tumor you have excised. Fortunately, we're seeing less and less of these patients because most of them now have been revised, and I think very few surgeons now and very few patients going for the hip resurfacing, much less than it used to be 15 years ago. Aseptic loosening, it was very common till, let's say, 15, 20 years ago. Now we're getting less and less problem with it, because aseptic loosening is now, with most of the modern implant, is getting less common. But they just still exist. You can see on this knee X-ray, there is a radiolucent line all around the tibia here, and the tibia starts tilted to one side. Almost there is a small fracture there. So we had to revise it to much bigger stem, relying on that metal sleeve to allow us better fixation here, because on the proximal side, there's not enough bone to support any fixation. So we rely on the fixation on the distal part. This is a cup, cemented cup, which is loose all around the cement area, and we have to revise it to uncemented shell. But it's getting less and less, and that's the advantage nowadays. So on my patient, if I discharge them at 6 weeks, I always tell them every 5 years is a good idea to have X-ray, check X-ray. If they start showing sign of loosening, or they start to have symptoms, then a discussion should be done whether they need something to be done about their joint replacement. We don't want them to leave them so long, like this gentleman on the left side. The cup loose, I'm not sure whether it projected well on your screen or not. You can see the cup is now almost vertical. It's gone almost inside the pelvis. There's a big cavity there. There's no bone to reconstruct. So the only way I had to do that, I had to do custom-made implants for him to fill the big cavity. This is all like eggshell behind here. Doesn't give me any fixation. This is open to his pelvis inside. So I have to do custom-made implant designed based on his bone defect, getting him through major reconstruction to rebuild his acetabular component. We definitely would like to see this patient much earlier, where the vision surgery can be much simpler than what we had to do at the end. Instability is much more common with hip. However, nowadays it's getting less and less a problem, because we are able to use a bigger femoral head. We used to use in the past 22 and 28 millimeter diameter. Now, most of the time we try to use 32 and 36 diameter, and the bigger the femoral head, the less likely the ball will jump out from inside the socket. And that's why the hip resurfacing and the metal head, as I showed you earlier, were so popular 10, 15 years ago, when everyone thought if I put a big metal ball there, it would never going to pop out from the socket, but it generated different type of problems. With the hip replacement, it still exists around 2% after primary hip replacement. And there are many reasons why a patient can dislocate. Could be patient factor. Sometimes patient either not compliant, or they are very high risk patients, like they have bad scoliosis, neuromuscular disorder, they have a lot of contractures. These patients are very high risk to dislocate. Could be procedure related. The implant wasn't put in the optimal position, so it's a surgical error, if you like. The implant could be put in much better position to minimize the risk of dislocation. And sometimes implant related factor, as I explained, like the size of the femoral head, how big the head you're going to put it in. In the knee, it's completely different category. Instability in knee, uncommon. This is gross instability, like dislocation. This is really rare phenomena. We don't see it quite often, but you get sometimes laxity between the collateral ligament if the knee wasn't balanced accurately, or there's quite mismatch between the muscle strength between quadriceps and hamstring. or the implant being used cruciate retaining, relying on the function of the posterior cruciate ligament and the PCL torn at later on or rupture later on, so the knee become unstable. I'm moving now completely to different problem other than instability. It's called iliopsoas tendinitis. It's a problem we see sometimes after hip replacement. When we can see on that picture, the iliopsoas tendon is running in the front of the hip joint. And here, as we saw in the previous images, you had a metal shell, although the underlying plastic. If that metal shell is proud, especially in smaller size pelvises, like small lady or small man, and the pelvis very small, and you put a shell with a slightly proud metal, that tendon could rub on that edge of the metal and causing tendinitis. Most of the time, it does settle by its own. It's common in the acute phase in the first period. It's coming with a growing pain. Quite common if you ask the patient to sit and flex against resistance, they give you quite specific growing pain. So treatment for it, we will try to manage it with non-steroidal anti-inflammatory tablets, muscle stretching, and we'll see how things progress. If persistent pain, we can inject them with ultrasound guided steroid injection. However, we have just to be careful where we to do the injection and who does it, because we can introduce infection and will lead us to the disaster we discussed earlier in the talk. So we have almost like a theater type room. We will do all this injection, or radiologists who specialize in musculoskeletal, mainly in joint replacement, do all our injection for these patients. If we see a patient sent for us for second opinion, and we think that the diagnosis is iliopsoas tendinitis, we do MRI scan to establish the diagnosis, and we take them into that room where the radiologist injected under ultrasound guided injection. In persistent cases, we have to think either I change the socket, I change the acetabulum, or we can do arthroscopic release of that tendon, which is basically cutting that tendon to allow it to be released. And by cutting it, you lose around 15% of the flexion in the hip joint, but relieve the pain. It's not common that we need that procedure. Most of the time is the ultrasound guided steroid injection does relieve the pain, but I do emphasize this should be done after review by a revision surgeon, because there are many reasons why a patient can have a growing pain after hip replacement. Stem fracture is not common, but it does exist. You can see with eye of faith, there's a big step here. Interesting, you see it every now and then, patient coming like to A&E with painful hip x-ray, and it's really sometimes really hard to pick up. And I see probably once a year one of these, and the patient usually being seen by 2, 3, 4 people in different levels, and persistent pain, no one knows what's going on. And of course, it's always easy to go retrospective to the first image and say, oh, it's very obvious it was a fracture, but sometimes the presentation vague to pick up stem fracture because it's such a rare phenomenon to happen. So as you can see, this lady, I've advised her to bigger stem, allow better fixation. Sometimes patient have multiple operation. You can argue, I don't know what's happening here, this is done somewhere else, but we can look at the lateral side at this x-ray where I'm putting my mouse, the second x-ray from the right side, and you can see on the lateral view the femoral component is way bigger than the actual end of the femur, the distal end of the femur. Now I couldn't tell whether this is just oversized femoral component from the surgeon who did the operation, or was there a bone resorption there. But we did a CT scan, we did revise him, and I couldn't find any useful bone to build up another knee replacement. So I have to do a distal femur replacement for this gentleman, as you can see on the image, because there's no enough bone to build up any component on it. So we have to revise it to bigger piece of metal, which we call distal femur replacement. Patella tilt or patella femoral joint maltracking is really it's common, and it's a very complex why some patient got it. Sometimes from the most surgeons go to the knee joint through the medial parapatellar approach, which means you open the skin in the midline, but you open the muscle on the medial side. And if that repair is not very tight, or the vastus medialis become weaker after surgery, the patella can tilt. Sometimes is the implant positioning, how you rotated the femoral component, the tracking of the patella itself. It is a very complex issue. It's not easy to resolve. The first line always will be physiotherapy, strengthening the quadriceps, strengthening the vastus medialis, trying to get that tracking to a better position. However, if that doesn't work, so you need really full assessment to see why the patella is not tracking and whether the pain the patient complaining from is from related to that X-ray images or related to something else. Finally, there's always another causes of pain. Doesn't always have to be the joint itself. So you see patient for, let's say, second opinion, patient look beautiful joint replacement, textbook joint replacement. You do blood tests, they don't have infection, but the patient is still in pain because the patient always have the spinal pathology. Why? That's the reason why the patient, yes, the initial X-ray did show arthritis in the knee joint or in the hip joint, but that arthritis was radiological finding rather than correlate to the clinical presentation of the patient. So it's so important to look to other causes. Where is the pain coming from? And sometimes it's really hard, especially in the hip pathology, and hence why we sometimes inject the patient with a local anesthesia and cortisone, not necessarily to treat the problem. We know we're not going to cure the problem, but we know just to establish if the patient responded to the injection and they come back say, yeah, I have no pain for 2 weeks, but the pain back again, then I know if I replace the hip in a few months down from the line, this patient is going to be happy. But if the patient comes back to me and say, you know what, your injection gave me zero difference, I'm still have the same pain, then the answer for this patient is not me. The answer to go to see my spinal surgical colleague for their management. And sometimes patient is just unhappy because we never able to match the expectation. And I see this for a lot for second opinion when patient come in. And sometimes the answer why patient is unhappy is clear because the patient had infection or loose implant or tendinitis or other problems. However, sometimes patient everything perfect, and again textbook X-ray, no infection. Then you ask the patient, how much pain did you have before the operation? And they say, oh, I didn't have much pain. Maybe when I play golf, but the patient, they told me I have really bad arthritis. And that's almost always in my book, that's the wrong answer. And that's wrong indication for surgery. I tell all my patients, this is not cancer and this is not heart surgery. If you're able to live with it, then you should continue living with it. If you're unable to live with it, if wake you up during the night, if limit your walking distance to 15, 20 minutes, affecting your quality of life, that's when we talk about surgery. Having arthritis on X-ray in its own without symptoms is not an indication for joint replacement because you will never able to match the patient expectation. In summary, unhappy hip and knee replacement, there is a cause why they are unhappy, and it could be the cause as simple as we operated too early, or could be they have infection. This is a serious symptom problem, or could be tendinitis that an injection can sort out the problem. Can be treatable. These a lot of them can be treatable, and a lot of patients with painful joint replacement can become much happier after they've been having the correct assessment. These patients should be referred to a revision joint replacement surgeon, not necessarily always to the primary surgeon, because there are a lot of outstanding surgeons worldwide, and they do only primary joint replacement. And nowadays, more of the revision surgery has been specialized in certain centers with a few surgeons doing in each center, because there's no point if someone does revision 2-3 times a year only. It's better that someone does revision every week who see these patients. So if the patient had a painful joint replacement, they need to be referred to a revision surgeon. If you think the patient has infection acutely, please do not give them antibiotics, refer them to the on-call service on the hospital. Chronically, refer them again to the, in each region now, there is almost a nominated hospital to deal with the infected joint replacement. So even if you send the patient, let's say, to Epsom, they know the Epsom team, we work very closely together, they send them to St. George's. But if you have the opportunity to refer the patient yourself, St. George's for the Southwest London is the nominated center for the infection joint replacement. So all the elective or the acute joint infection will be much faster to send the patient directly to St. George's, because that's where we deal with it. And I'm coming to the end. I can see there's 2 questions there. I will stop sharing. This is my email address there, Sulaiman.Alazzawi #1 at nhs.net. I'm happy for anyone who wants to email me later on, or even want to come to observe a surgery, or want to discuss anything, or want to refer a patient. I'm very happy to receive the email directly. I will stop sharing my presentation now, and I think there's a couple of questions.
Hi, thank you very much for that. That's
Thank
brilliant.
you.
I'll just go through the questions for you. So from Nikhil, how long are the revisions lasting with the new replacements?
So it lasts as a primary replacement. In terms of longevity implant, it lasts as same as primary replacement, but there are bigger operation, and the bigger operation always associated with slightly higher complication rate. Like first, the patient tend to be much more older now because they tend to have the primary operation 20, 30 years ago. And they are slightly higher risk of infection, high risk of blood clot, high risk, etc., etc. But in terms of implant longevity, it lasts as long as any modern primary knee replacement or primary hip replacement.
Thank you. There's another one from Nikhil. With dysplasia being more recognized, are you pro early hip replacement?
So that's very interesting. So it depends who you ask about the dysplasia. So I did my fellowship for joint replacement in North America in Vancouver, and I did ask the question about periacetabular osteotomy for younger patients, and seeing the trend to move away from it. And I say this is different school, different, depends on what you believe into it. The reason why they moved away from it, because they found actually you can do periacetabular osteotomy, but most of the time patients are not so happy after periacetabular osteotomy. They stay for 1 or 2 years on and off, not super happy. Then you start injecting them, and then after 3-4 years, they may end up with hip replacement. While nowadays, I know the result of hip replacement, and I know if I do a hip replacement today in a patient and everything goes well, no infection, no blood clot, everything went as planned, I will not see the face of this patient for 20 to 30 years. The patient will be happy. One operation for 20, 30 years at least, I don't need to see this patient again. However, I fully appreciate if you have a 19-year-old lady who is doesn't have any degenerative changes, pristine hip joint, only with dysplasia, with minimum pain, you may want to do periacetabular osteotomy because the hip replacement is far away from that.
Thank you. Are there any other questions from anybody? Those are only 2 so far. You must have answered all of them in your very comprehensive presentation.
I hope so. I hope so. And as I say, any of these topics are really a topic in its own, and you can have a 2-hour discussion about any of the iliopsoas tendinitis, the patellar tracking. Any one of them is a big topic in their own. But I just want to give you a feel that there are reasons why sometimes patients are unhappy. Fortunately, it's very uncommon. We see a lot of them at George's because we are in the complex arthroplasty unit, because we are revision center, so we get seen this. But in normal practice, we don't see many of unhappy patients. Most patients are very happy. So my primary joints are, most of them are happy. As expected in national average, 90% with the hip replacement, above around 85% of knee replacement are happy. And then you get these odd occasion when a patient is unhappy, and it's important to see this patient because sometimes there is a reason why they are unhappy.
There is actually one more question from Nikhil.
Yeah.
Would the POA be able to then have a total hip replacement?
Yes, they will be. However, the reason why, Nikhil, we moved, and I am completely on that school. So if I see a young patient with slightly degenerative changes and they are in severe pain, I either try to walk them up non-operatively until they need a hip replacement, and I do the hip replacement for them, or go straight. That's my strategy for them, because if you do it, and I've done it many times in patients who have previous multiple periacetabular osteotomy, you go through a soft tissue, which is a scarred soft tissue. You're going through not a new tissue or tissue being scarred. You go to multiple scar area. The anatomy has changed now. The bone stock has changed. So doing the hip replacement now is not anymore a straightforward hip replacement. It's slightly more complex hip replacement. And in terms of dissection, now you're going through a revision surgery dissection. Everything's scarred, so we have to dissect all the tissue, get the sciatic nerve out of the way because we use posterior approach for revision. And slightly technically more demanding. It's still achievable, but what's the point? Because I haven't seen many patients after periacetabular osteotomy, they disappear for 15 years, they never come back. Most of them, they will come back for hip replacement within 3-5 years, and hence my comment, the outcome of hip replacement nowadays is really so good. So if you can run them with the cortisone injection, variable type injection, physio, until they feel they need it, and you do one operation, you're not going to go very well, and you leave it. I would go with that school. But I fully appreciate if you ask the question, you might get 10 different answers. And there are centers in the UK, they are very happy. They disagree with this, and they say, actually, periacetabular osteotomy is the way forward. You don't need to put metal too early. There's no right or wrong answer. I mean, depends what the patient wants and what the surgeon believes best. There's enough evidence to support each one of these thoughts.
We've got a couple more questions. So
Yes,
Alison said, fantastic, very clear. And then we have somebody who's asked, when would you suggest an injection after replacement surgery? And is there a time frame to avoid steroid injection around the replaced joint?
That's very good question. Injection around a steroid injection, I will say is not for, other than the revision surgeon, I will say the indication is very limited. The risk is very high. I just saw yesterday a patient, really sad story. He had hip replacement, fantastic result 2 years ago, fell and attended outpatient clinic, and sadly a member of the team saw the patient and say, oh, you have traumatic bursitis, let me inject you with cortisone. And now the patient has discharging sinus on the lateral side of his hip from that steroid injection, which caused infection. The patient implant has subsided and now perforating through his femur, so he's impending periprosthetic fracture, so we have to give him crutches, non-weight bearing, and now we line him up to have very urgent revision, 2-stage revision. So I will, by default, I will try to avoid injecting steroid injection to any joint, so make us very nervous, because the downside if things went wrong will be really big. The expense will be so big, so try to avoid it. If we're going to inject, we need to know why we are injecting. So for the knee, for example, sometimes they have pain around the insertion of the hamstring on the medial side. Sometimes they have around the insertion of ITB band. This is especially if the tibial component is slightly oversized, meaning the metal hanging on the side of the bone, and then there is a soft tissue rubbing around it. There are certain, so we need to know what we are injecting, why we are injecting, and what's the outcome. If it does work, what's the next step? If it does work, and the pain recur again, am I releasing the ITB? What I'm going to do about it? And the same with the hip joint. If I'm injecting iliopsoas tendon, I need to know. So being me a bit OCD about the joint replacement, I will not, even when I request the injection, it will be 1 or 2 named radiologists who work very closely within the same team, because I know it's going to be done in a special room with special technique that we all agreed with it. Because if infection happen, and it can happen, infection can happen, is a disaster. So I will try in general avoid injecting after joint replacement as much as I can. And if injection need to be done, then I suggest should be done by a revision surgeon who's requested by a revision surgeon who can act on the result of this injection. Because injecting is one thing, but then patient come back to you. And the worst things when you don't know where they injected, the patient responded to the pain and they are better, but you never figure out what they injected. So that's the answer to that. I have that answer the questions for the injection.
There are 2 more questions, but I'll just jump to the second one because it is to do with the injection and how many corticosteroid injections would you allow for iliopsoas tendinopathy?
So there's no number limits. There's no a book or a rule or guidelines say 6 injection. If you do 7, we take you to the court. If you don't do 5, there's no rule. I think for me, most important things, I do CT scan in this case. I look at the X-ray. 1 injection is tolerable for iliopsoas tendinitis. If there's persistent severe pain, I want to do CT scan because I want to see where's the acetabular component sitting. And I want to see if it's really super proud, then I have to tell the patient, look, we can inject it again. It may or may not work, but we might either cut that tendon, which is keyhole surgery, or we might have to change the acetabular component for you. We might have to change the cup for you because your cup's so proud, and injecting it will not give you the answer because the problem still, the engine of the problem still does exist. And that's the way. So there's no limit, but we need to know if it's just little irritation and doing 1 or 2 injections, that's fine. But I will not inject them more than twice for sure for me, because if they're persistent, I was thinking either iliopsoas tendinotomy or I'm thinking revising the cup if the cup is so big and causing such a soft tissue irritation for them.
Brilliant, thank you. And then from Becky, what is helpful to include in a referral for you that you're receiving from physio to help with planning? like X-rays, preclinic or functional outcome measures?
X-ray for me doesn't help me much because I'm always repeating the X-rays again on date of arrival, and sometimes we're requesting slightly different view, depends on the presentation. But I don't mind if the patient say, hey, we done an X-ray shows suspicion of loosening. I think X-ray is very useful from your point of view to give you that a bit of insight what's going on, because sometimes you see a patient with, let's say, hip only symptoms, the story doesn't add up, and having that adjunct of X-ray just to reassure you I'm not missing here a loose implant or periprosthetic fracture or dislocation or something wrong, give you a bit of reassurance. Okay, I can try physio for another 2 or 3 months. I will assess the progress. So doing the X-ray is very good exercise, but I don't mind to get a referral directly to say, look, I saw this patient had knee replacement, is now very stiff. The range of motion is 20 to 60. He's been trying different physio, or he had knee replacement. He's never been happy after knee replacement. Very that. For me, what will be useful to know what exercises this patient have tried, and how long, and was he engaging into it or not. The classic example of this patient with weak abductors with hip dislocation. I want to know how weak is his abductor. Is he dislocating because there's no soft tissue tension whatsoever? Or is he being have dead abductors from the operation because the nerve was cut during the operation, or he had multiple surgery? I want to know what exercise he had. Did he try really the exercise well and didn't work? And the same with a stiff knee. If I see a patient and say, this patient has a stiff knee, they had knee replacement 6 months ago, they have 1 physiotherapy session and now stiff, then in my idea, I'm moving, okay, there is a reason why they get stiff. Maybe they didn't exercise. But if you tell me, I have a patient had knee replacement, range of motion on day 3 was 0 to 100, proper physiotherapy, we have 6 session physio, doing really well. And now the range of motion 20 to 70, I will get very nervous about doing anything for this patient. I have to counsel them very carefully, because this patient have more tendency to have arthrofibrosis. That means these patients tend to, their tissue for unknown reason to me or to anyone, maybe genetic reason, maybe their collagen, they get to get more liable to have fibrosis and scar tissue. So I have to be very careful, because they were 0 to 110 post-op. They have good physiotherapy, they progress, and then something happened, make them decline. And so that's so important, so useful for me.
Sam says, thank you, very useful. And then Ali's got a question for patients not ready to have knee surgery. What are your thoughts of landmark versus ultrasound injection?
What's landmark?
Do you mean sort of like landmark injection versus guided injection, maybe? Ali, if you just want to type it in there. Or maybe, sorry, landmark versus ultrasound. No.
Oh, no, yeah, I think you mean like anatomical landmark. I have no issue. I'm very happy to inject them landmark. The only one I insist on ultrasound guided if they're very obese patient. If someone BMI 52, which I tell them, look, BMI 52, you need really good bariatric surgeon. You need to work on this. You need an injection. I'm not going to inject them blindly in the clinic, because if the injection hasn't worked, is it me or is it the actually because they have bad arthritis? And the hip always not landmark. The hip joint always the actual intra-articular injection should be either ultrasound or X-ray guided. Trochanteric bursitis in native hip, not in the hip replacement. In the native hip, depends. You can inject the most area of tenderness, or you can inject the ultrasound guided. Depends how comfortable with it. With the knee, if you're comfortable and find the landmark, I inject my patients sometimes if the time in the clinic allow me to inject them. Is more, I think it's very straightforward injection. I don't think there's a problem with it. But I'm talking only about native joint, not the joint replacement here, because joint replacement, I don't do injection in the clinic. If I'm going to do it, I do it inside the operating theater. I will do it in the special radiology suite where we do all these injection. And I do sometimes injection for joint replacement for diagnostic tool. Like if the patient has a painful joint replacement, I'm not sure the loosening of the cup, for example, in the hip joint, explaining their symptoms. So I take them to the operating room in theater, in my operating list, inject them with local anesthesia, and I assess them after that to see how much pain relief, to see whether actually the losing of the cup explaining their symptoms when they have very bad spinal pathology, or is not. So for diagnostic tool. But for the native, I'm fine to inject native knees in the clinic.
Brilliant. Thank you. I think that's all the questions.
Perfect.
So thank you very much. We will send you tomorrow, if you could please fill in the feedback form for us, and you'll receive an attendance certificate for your CPD folder. And thank you very much, Mr. Alazzawi. That was brilliant and very comprehensive.
Bodine, thank you so much, and thank you for everyone staying late.
And we'll let you know about the next ones.
Thank you so much indeed. Thanks for the invite.
Thanks, everyone. Take care.
Thank you. Bye.
Bye.